Thank you for joining us today. I'm Adam Cano, a member of the class of 1990 and parent of a current junior at the University of Rochester. I'm also a member of the Alumni Board, which is a group of about 25 members representing each of the university schools with the purpose of engaging all alumni and students in a lifelong connection with one another and with the university. Today's lecture is part of a new series called Experience Rochester that will exemplify the university's commitment to lifelong learning. We will feature topics and speakers that are unique to the university, and for now, their experiences will take place virtually, and eventually we hope you'll join us for live in-person events once again. We have a range of registrants joining us for this session, hundreds of parents, current students, alumni, dating as far back as I believe the class of 1956, and quite a few members from the 1950s era. So thank you for all of you for joining us. Before the webinar begins, I just want to cover a few Zoom webinar tips for those of you who are new to this platform. If you'd like to ask a question, please submit it through the Q&A function that is located at the bottom of the screen. Professor Raz will take questions at the end of the presentation. If you'd like to view this session with closed captions, please click on the CC on the bottom toolbar and you can select Turn on Subtitles. And if you're having any trouble viewing the webinar, you might try calling in and listening on the phone number that was included in your confirmation email. Now, I would like to introduce today's speaker. Mical Raz holds appointments in both the School of Arts and Sciences as the Charles E. and Dale L. Phelps Professor in Public Policy and Health, as well as at the School of Medicine and Dentistry as an Associate Professor of Clinical Medicine. In addition, she is a practicing physician at URMC's Strong Memorial Hospital. Professor Raz frequently contributes to the Washington Post and is the author of 3 books, including her newest book, which is titled Abusive Policies: How the American Child Welfare System Lost Its Way, which will be out this fall via UNC Press. Victoria Blackham, today's moderator, became a U of R alumna just this past weekend, so we all join in congratulating her. She majored in economics and minored in psychology, was a member of the varsity women's rowing team, and will participate in the Take 5 program next year. So again, thank you all for joining us, and I'll turn it over to Professor Raz.
All right, thanks so much for this kind introduction, and thanks to all of you for being here virtually today. And I'll be really excited to hear your questions and have a conversation at the end of the presentation. I'm going to talk about a few health policy lessons that we can take from this pandemic from a historical perspective. This is really not an exhaustive list, and especially since we're now in the middle of the pandemic, it's quite hard to say how this is going to end and what we're going to take from it. I still think it can be illuminating to look at a few key moments and look at them from a broader historical trajectory and try to see what we can learn. My working assumption here is that this pandemic has shed light on many of the major underlying flaws of the American healthcare system, many that were perhaps clear to you as healthcare professionals or public health scholars or clinicians, and to many who have experienced the healthcare system from the vantage point of somebody who might be vulnerable. But most Americans experience only the good parts of the healthcare system, the high-tech experience of excellent care. So these downsides were not visible to many. This pandemic has brought the many dysfunctions of our healthcare system into broad visibility, and a historical analysis can both enhance our understanding of why the healthcare system works or maybe doesn't work the way it does, and also what it would take to fix it. So first slide, please. So the first thing I want to talk about is employer-sponsored health insurance and how that might change with the aftermath of this pandemic. Next slide, please. So this is a pretty busy slide that shows how most Americans get access to health insurance and why it matters. And there's 2 things I'd really like you to take from this. The first is that most Americans get their health insurance from an employer-sponsored insurance. So they get their insurance from their workplace. And the second is that there's huge fragmentation in how people get their insurance, which is important because that way people's interests don't really align. In other countries where there's fewer ways to get insurance or one way to get insurance, then people have the same interests. and it's easy to mobilize them for change. Here, we are a very diverse group of how we get insurance. But going back to this, over 60% of Americans get health insurance through their employer. And that number should alarm us when we learn about rising unemployment in the aftermath of this pandemic. Americans view health insurance and access to healthcare as a privilege earned through employment rather than a fundamental right. And attempts to alter this relationship have been met with intractable resistance. Powerful interest groups, including the insurance industry, powerful unions, and high earners have worked to block any attempts to alter this fundamental relationship between employment and access to healthcare. This has a long history. Why do we need insurance at all? And this has to do with technological advances in healthcare. In the 19th century, there was really no need for health insurance. There was not much to offer, and you could get your healthcare services from your doctor in the community. As healthcare was transformed into hospitals and to hospitals as a major site of care, and there's more interventions, more surgeries, more things we can offer, then the costs are rising and increasingly became out of the scope for most middle-class Americans. That was why insurance suddenly came into being. And in the 1930s, we started seeing a model of employer-sponsored health insurance, which became increasingly popular. Next slide, please. And we see, from the late 30s and 40s, when very few people had health insurance, we're looking, the top line is total resident population, and then the bottom lines are the kind of insurance people have: hospital insurance, surgical insurance, or regular medical insurance. So we're looking from a situation where most people don't have insurance to most people have insurance through their employers. So why did this model of employer-sponsored insurance, why was it so successful? All right, so the first is, by design. People who work at jobs that are more likely to be young and healthy and able-bodied, so they're a relatively healthy bunch, which insurance companies are eager to insure. So by design, insurance companies are eager to insure workers. It makes sense for them. It's a risk pool that benefits them. Second, in the early 40s, President Roosevelt signed an executive order that froze wages amidst the war. Benefits, however, were exempt. So employers could entice workers with health insurance rather than with higher pay that they couldn't offer. The following year, the IRS officially exempted health insurance benefits from being taxed. So we have this quirk. Since the 1940s, we don't tax health insurance benefits. And that is a boon for employees, but particularly to high earners. You have to make a lot of money to enjoy a tax benefit or a tax shield. And also, of course, for unions who can negotiate for benefits. Third, insurers work to mold public opinion about health insurance as a benefit earned through hard work rather than a right. And this was opinion that was carefully cultivated by the insurance companies in forms of commercials and kind of public service announcements. This was inevitable. You could think, for instance, that not being able to afford healthcare would be a failure of your government or a failure of the society you live in, but rather this was seen as an individual responsibility that you earn through work. And finally, through the early decades of the 20th century, there was a lot of talk of the need for a national health insurance. People wanted healthcare, people wanted to be able to afford it. The employer-sponsored health insurance and these private companies, they stepped in to fill a void, which was important, but they particularly fulfill the needs of middle-class Americans who work, a very dominant population. So by filling this void it undercut middle-class support for a program for insurance. As the needs of relatively healthy working middle-class people were met by the private sector, it became increasingly difficult to mobilize a political constituency for change. Ultimately, creating employer-sponsored insurance helped perpetuate its existence and make sure that there would be no alternatives. So that's kind of the brief historical overview of why we have employer-sponsored insurance and why it's been so successful or so resistant to change. But by the 1960s, as we see in the graph, a lot of people have employer-sponsored insurance, and most of it is employer-sponsored. It became the primary way in which Americans were insured. Still, this model leaves a lot of people behind. As you can imagine, older people who don't work, disabled people who cannot work, children, people who become newly unemployed. So in response, there were different carve-outs for people for whom the employer-sponsored insurance model doesn't work. Middle-class Americans embraced their generous employer-sponsored insurance, the security provided, and the belief that they earned it. And those who could not have it, they needed to find alternative programming. And that helped lead to the creation in the 60s of Medicare and Medicaid, and later other programs like Children's Health Insurance Program. So employer-sponsored insurance clearly has many downsides. It became, however, commonly perceived as the American way. And there are many situations in which employer-sponsored insurance might fail people in setting of job loss, divorce from a breadwinner leading to the loss of benefits, a new medical disability that you suddenly can't work. But these situations were interpreted by policymakers not as a sign that the structure of employer-sponsored insurance is not tenable, but rather that we need specific carve-outs. So at each point, we had a different solution. For instance, we have COBRA for individuals who lose their health insurance that they continue benefit for a certain period of time. So any attempts to replace this model were unsuccessful because there's a deep attachment to this basic model of employer-sponsored insurance. And the landmark reforms of the Affordable Care Act, which were incredibly contentious in passing and are always being contested, including now in the Supreme Court, they were only feasible politically because they were based on a model of employer-sponsored insurance with a plan to expand Medicaid to all low-income Americans. But what does this mean now, and why is it suddenly relevant? So more than 35 million Americans filed for unemployment in the past 2 months, reflecting the far-reaching effect of this new pandemic. Slide, please. And we look at all the people who have experienced job loss as of early May. And we're looking at newly uninsured, who are estimated to be close to 30 million. This is from 2 weeks ago, so the numbers are undoubtedly higher. Amidst a global pandemic, increasing the number of uninsured Americans adds fuel to an already devastating fire. So we have a lot of newly uninsured Americans, but many of them might be eligible for publicly subsidized health insurance through either Medicaid, particularly in states that did expand Medicaid, or subsidies to purchase health insurance through the marketplace created by the Affordable Care Act, which is good, it's reassuring. But there's still millions of Americans who will not be eligible. And the fact that you are eligible doesn't mean it will happen, right? So many people are not aware of their eligibility for new forms of insurance, or some may not be able to afford even the subsidized premiums. So how many newly uninsured Americans will enroll for alternative coverage remains to be seen. Also, many of these options depend on the Affordable Care Act. And even now, senators who have repeatedly voted to repeal the Affordable Care Act are directing their constituents to sign up for the exchanges when they are newly uninsured. But right now, the Affordable Care Act is being contested and there will be a Supreme Court ruling. So it is unclear for how long this option will be available. So this has the potential to create a perfect storm. People who do not have health insurance often seek care too late. They suffer financial devastation and bankruptcy. They have worse overall health, and we know a higher risk of death than their insured neighbors. This is at baseline. What happened at a pandemic is probably going to be worse. For hospitals that are across the country that are already struggling financially, a soaring number of uninsured Americans may be devastating. So when people don't have health insurance, it's not that they don't get health care, right? They still go to the hospital, and hospitals still treat them, but nobody pays for this care. So hospitals experience increasing numbers of uncompensated care encounters, which puts hospitals at financial risk. So why this may suddenly change? So for many years, we've had middle-class Americans who've had employer-sponsored insurance have been very happy with it and very resistant to change. And this idea that healthcare is an entitlement and that we earn these benefits. And people are reluctant to change when things are good for them. And that kind of ties back to the slide I showed early, that we have so many Americans getting health insurance in different ways. It's hard to have them have the same interests in mind and to mobilize them. But suddenly we have large numbers of newly uninsured Americans that are seen to be newly uninsured, quote, for no fault of their own. And so I'm just saying that, quote, because it's never someone's fault that they don't have insurance. It's usually an issue of affordability. But this is a much more sympathetic group that will be easier to mobilize support for. And this is also an unprecedented combination of both a global health threat, a pandemic, alongside economic downturn. We've experienced both, but it's rare to experience both at the same time to the magnitude we're experiencing right now. So what could happen? well, one thing that could happen is that we would pass the carve-out act of the health insurance for people who lost their insurance during the coronavirus of 2019 act, which is possible because that's usually how we do things. We find a quick fix solution to keep the employer-sponsored model at base, and then find a solution how to work around it. But we're looking at millions and millions of Americans who have lost their jobs, and with an election year and a lot of appetite for change, this might be the time when we talk about structural changes or systemic changes to how healthcare insurance is delivered. And we know that at base, employer-sponsored insurance is not an efficient way to deliver care. Having a third party responsible for cost leads to a lot of cost shifting in which there's really no incentive for savings. Insurance companies spend more money, they roll those costs back to the employer pays them and responds by not raising their workers' wages. So everyone kind of only sees one small bit of the bigger picture, and there's no way to coordinate and try to cut down costs. So overall, not a very efficient way to do it. We see it's not a tenable way to do it in pandemic, combined with rising unemployment. So this might be the moment in which we address employer-sponsored insurance. So that was the first point I wanted to talk about, the history and trajectory of employer-sponsored insurance. My next slide is going to be about the next topic. And this is about how the pandemic is making the invisible visible in many ways. So it makes it literally, we suddenly worry about tiny microbes we cannot see, about what, drops of spit coming from our mouths when we sing, when we talk. We suddenly worry about people who have been invisible in society, the poor, the low-wage workers that we've underappreciated, but suddenly we call them essential and applaud them. Undocumented workers laboring at meatpacking factories, the homeless. Famed historian of epidemics Charles Rosenberg playfully referred to this as the "who knew" phenomenon. This is the first time we're discovering poverty. We're discovering all these things that have been lurking in the background the entire time. So while we're battling this new, unknown, and acute disease, it might seem like a weird time to point out the risks of a chronic illness. But we do know something from the history of pandemics is that we always grasp onto false reassurances and try to say that this will never happen to us. It only happens to other people. It happened, we've Native Americans, we've Chinese, we tried Europeans, but always ways in which we say this is not us, we're going to deflect. And that certainly was evident with this pandemic. In January, we're saying, oh, this will never come to the United States and China, this will never leave Italy, there's no way it's going to happen to us, Americans have nothing to fear. Politicians and policymakers wasted valuable time magically convincing themselves and their constituents that the virus would not reach our country, or that somehow stopping travel from overseas would be an effective way to prevent spread that's already happening in our community. And in this, trying to talk about how this won't affect us and how we don't see these threats, the other thing is talking about it won't happen to us personally because we're young, we're healthy, we don't have all these illnesses, it only happens to other people. But there is a risk here. And for reasons that have not been completely elucidated, SARS-CoV-2, the virus that causes COVID-19, appears to be far more severe in individuals who have underlying chronic disease, and particularly some chronic diseases. In a recent study in the prestigious JAMA, the Journal of the American Medical Association, they found that they looked at 5,700 adults who were hospitalized in New York City hospitals with the coronavirus. 88% had at least 2 significant underlying medical conditions or comorbidities. And the most common ones were hypertension, obesity, and diabetes, with significant overlap between these conditions. I'm going to ask for another slide, please. In fact, on a recent interview on CNN's State of the Union, Secretary of Health and Human Services, Alex Azar, was asked a pointed question, why the US, which has less than 5% of the world population, made up about 30% of the total reported coronavirus deaths globally, almost 90,000. And this 90,000, of course, is undoubtedly an underestimate of the pandemic's true toll. In response, Azar extolled the success of the US response and noted, I think you can see that in the slide, that the US is a population with significant unhealthy comorbidities that do make many individuals in our community, in particular African-American minority communities, particularly at risk here. And I hope you can see the full quote there. So Tapper asked him, are you blaming individuals for their illness? He said, oh, it's not about fault. A notion he said was absurd, but rather about simple epidemiology. If you have more hypertension, if you have more diabetes, you'd have a greater risk of complications. So I think this statement is incredibly irresponsible for many reasons. And I don't think that the incidence of chronic illness is a primary reason for how hard our country has been hit by the coronavirus. But I'm going to put that aside for a minute. When the Secretary of Health and Human Services notes how unhealthy our country is, this really does not have the exculpatory effect he may think it does. I mean, it is kind of his job. Decades of underinvestment in the social determinants of health, housing, education, income, transportation, access to healthy, affordable food, and employment greatly influence the health and quality of life in communities. Furthermore, we know that in the US, there are great barriers to accessing and affording healthcare and medications, even among those who are lucky enough to have insurance. And we just talked about what might happen to some of those people who have insurance. With the pandemic, they might find themselves newly uninsured. These disparities in health attainment mirror social and racial disparities. I mean, we know that zip code is a #1 determinant for your lifespan. So how do we tie this all together? So it is an opportunity to ask, why are Americans so unhealthy? Can we have a next slide, please? Why is there so much chronic disease in the United States? And we do know that Americans do suffer from chronic disease. And how can we fix it? So it's certainly not assign individual blame or say, what can we do? Coronavirus is bad because everyone's sick. But, how can we focus, on a systemic way to improve the health of our communities? But there are risks here also. When we talk about how it might only hurt people with chronic illness, it's one way to make this epidemic or pandemic invisible again. We know historically that pandemics gain attention and demand investment and solution when they're perceived as hurting us. So, for instance, the HIV/AIDS epidemic, when it was only hurting a marginalized population, when it was only the gay people, so that was how it was seen to be, it unfortunately led to tragic political inaction. But when suddenly there were white mothers who were infected by transfusion and childbirth, they became, in many ways, the face of the innocent victim of HIV. And that led to a lot of political mobilization. Today, African American men are the highest increasing demographic in new HIV infection in the United States. There is, in fact, an epidemic of HIV in some communities, but you'd barely hear about that. You'd think that this is no longer a problem because in many ways it has become invisible. And this is there's a historical cycle to this. We think about pandemics as threats when they affect people that we care about as a society. And when it affects poor people, when it affects the others, when it affects, racial or ethnic minorities, it suddenly no longer becomes a problem. So I could foresee a situation in which this pandemic ends not by people stop getting sick, but it's people who get sick are people we do not care about as a society. And we already see that in some of the states that are reopening. Can you get the next slide, please? So this is a recent piece in the Washington Post that talks about Georgia reopening and people going out to get their nails. And I think the quote I've highlighted is really the money quote. When you start seeing where the cases are coming from and the demographics, I'm not worried, says one person interviewed in the Washington Post. So certainly it's just one quote, but that's really the feeling. We're having 2,000 people die a day, but we've realized that these are not people society values anymore. These are invisible people. So we are, pushing forward and reopening. So I think there's a lesson from history about visibility and invisibility. And this ties to bigger pictures about chronic disease, because there's a risk here. When we say that the people who don't matter are people with chronic disease, but we're a country with such high rates of chronic disease, then this is complicated. And even more so in a political setting in which one party in power particularly relies on an older demographic. And this older demographic tends, in fact, to have a lot of chronic disease. So there are political risks to this approach that, chronic illness is a problem of those who have chronic illness. So first of all, I think it's interesting to look at these tensions between who we see and who we do not, what we see during the pandemic and who we value, but also to think about solutions and how solutions can address, chronic illness in the United States in a way that doesn't say, you know, oh, the chronically ill, that's just how it is, but rather thinks about structural changes to make sure that when we move forward, we will be focusing on making the population healthier. All right, next slide, please. And the last point I want to make is that we're facing really big problems, and we're thinking about big solutions. But sometimes there really are simpler solutions that have been proven to be effective. And what do I mean by that? Next slide, please. So this is a kind of complicated slide that may be hard to see, but the gist of it, and this is from a study of the influenza pandemic in 1918 and 1919 that was published over a decade ago in the JAMA, the Journal of the American Medical Association, and looks at different cities and how they responded to the pandemic and when they instituted what is called non-pharmaceutical interventions. So obviously there's no medicine for influenza, there was no vaccine for influenza, but there was no non-pharmaceutical ways to address this. And those were what we call today the social distancing. So it's school closures, public closures, quarantines, and so on. And it's hard, hard to look at exactly the different slides, but what we see here, we're comparing, for instance, St. Louis on the one side and New York City on the other, that states that acted quickly had longer time until they reached the peak mortality. Their peaks were lower, so the peaks of mortality were lower, and overall they had less mortality. So these interventions, they worked. And of course, at the time, like now, there was a lot of pushback. There was even an anti-masking league, similar to the kind of resistance we hear now about people who do not want to wear masks in public, which I'll talk about in just a second. But we do know that these measures work. And there is a risk here when our politicians are talking about taking unproven medications to prevent this pandemic, or discussing ways to hasten a vaccine and what's called the Operation Warp Speed, which is completely unproven and kind of pie in the sky when we do have methods that are effective and proven. So we have to be wary of overpromising technological solutions while we're underemphasizing simple preventative measures. And that's something also we can think about in vaccines. So, everyone's saying in a year or so we'll have a vaccine. There's no assurance. I mean, I wish that's true. It may be true. But on the flip side, HIV, which is admittedly a completely different virus, it's been 35 years and we don't have a vaccine. And then there have been, dozens and dozens of trials looking for HIV vaccines at an estimated yearly cost of $500 million, and we're still not there yet. On the flip side, we do know that condoms and sexual education, they do work to prevent HIV. And now we do know that medications are able to reduce transmission with antiviral medications that are taken. So there's a huge disconnect between what works and what is politically palatable or kind of publicly exciting. So it's kind of good for us, thinking about the history of public health, to call attention to what we think is effective. And the same thing about malaria. I mean, there was so much work looking for a malaria vaccine and new medications, when in fact what we know is really effective is insecticide infused mosquito nets. So kind of just barrier methods to make sure that there's no mosquito access. So kind of thinking about what works and what doesn't. Next slide, please. And this just came out in the New York Times. I think yesterday I saw this, that was talking about how if we had implemented these social distancing measures earlier, we might have saved thousands and thousands of lives. This is a pretty compelling model. Of course, it's only a model. We don't know what would have happened, but this does make a good argument that tens of thousands of deaths may have been avoided if we had implemented the social distancing measures earlier. But they're very unpopular. It's particularly hard to implement them when there are no cases documented in the community. Of course, one of the reasons there were no cases was because there was not testing. And we have seen, comparisons of New York's response to the West Coast. And we know that delay in New York closures have led to a hastened spread within communities. So if we had learned from history and had thought about, the history of pandemics and preventative measures, we may have acted quicker and been able to save lives. I'm going to have one more slide, please. And this is pictures of politicians working in close quarters, people, and not wearing masks. which has a long history, of course, but it calls attention to this resistance or reluctance to simple proven measures, while a huge investment into unclear plans for prevention. You know, the president himself says he takes an unproven drug, and the funding and the public partnerships to look for a vaccine, when, you know, other countries effectively send masks to all their residents and say, you know, masking is mandatory. And of course, there's a history to this. And as I mentioned a few minutes earlier, there were anti-mask activists in the early 20th century. There will always be individuals who reject or object to public health measures. It would be easier to implement them if our leadership was also on the same page with having these measures in place. So I hope I've had a chance to kind of call attention to what I think are key lessons from this pandemic, and how we can think with historical tools and our historical analysis to think about health policy today, and to figure out what changes we can advocate from that would be educated from a historical perspective. So I look forward to taking your questions.
Hi. So we've received so many great questions, so I'm just going to jump right in. First, a question from Elizabeth. She asks, how will the pandemic affect the public and political pressures to adopt a more cost-effective universal system? And I kind of wanted to follow up on that also. You talked a lot about marginalized populations and how they're kind of invisible in our political system. So how can we give them the representation that they need in order to make a change in how we administer our healthcare system?
Yeah, that's a great question. And I'm sure we always wish we had answers for this. But I think there is a possibility of advocating for change, in as much as the composition of individuals who don't have access to healthcare has changed. The composition of those who don't have health insurance has changed. You know, my mother-in-law used to drive a big car that had a bumper sticker that said Obamacare works for those who don't, until her employer stopped offering health insurance, and then she went and gladly signed up to the Affordable Care Act. And I'm not saying this as a judgment. I'm thrilled she has health insurance. People's values and opinions change when it affects them personally in different ways. So I think that, you know, we will have an opportunity for political mobilization. Now, how do we empower the marginalized populations? And this is really hard, because how do we empower people who are actually sick and dying right now? Right? I mean, in some communities have been so hard hit. And I think some of it is, you know, we have a responsibility to advocate. You know, all of us, particularly people in positions of responsibility and power, have a responsibility to advocate for individuals who are marginalized, and you know, be stewards of public resources, and also to push back when we're talking about sacrificing the weak for the economy, or reopening prematurely. And, you know, when people are standing there with signs that say, I need a haircut, they're not saying, I want to go back to work. They're saying, I want other people to go back to work to serve me. And we have to keep that in mind. So when we're adopting we're reporting on discourses of individuals who are objecting to the public health measures, we have to think, you know, whose voices are being heard and amplified and whose aren't. And the individuals who are out there working as essential workers and low-paid jobs, they're not out there standing with signs because they're out there working. So I don't have a good answer for this. I have, you know, different thoughts about how we can think about this, advocate, and talk about this. But I think we do have an opportunity to affect change.
Richard asked about how other democracies have arranged their healthcare in order to handle this pandemic. So I think that question is kind of stemming from, how do we know that these structural changes would actually be able to handle the pandemic in a more effective way? Could you compare our model to another country that has had much more success because of the structural differences in their healthcare system? Yeah,
I mean, that's also, I mean, the different healthcare systems are structured differently, but the United States is unique in many ways, and one of it is in its reliance on the employer-sponsored insurance, which I've discussed at length, and the other is how much we're financially dependent on volume in hospitals. And so hospitals now are struggling, including our own here in Rochester, with a reduction of volume of procedures, of elective procedures. So it's hard to harness the healthcare system to shut down all its operations and only focus on the pandemic when that is strictly the opposite of what their bottom line needs. So a lot of it has to do with how healthcare is financed. Here, it's at base mostly a fee-for-service system in which healthcare system, they need to replace knees and they need to do interventions in order to get money. And that has been a major barrier because now hospitals are struggling. Some may close, they're furloughing doctors, and nurses and other healthcare workers because they don't have money to pay. That cannot be good in general, and certainly not in a pandemic. So I think, in other countries, there have been stricter shutdown measures in most countries. Certainly there are other models such as Sweden, but most countries have had stricter shutdown models. When we talk here about how we've shut down everything, sure, but we're nowhere near close to what other European countries have done much earlier. And then the ones that have nationalized healthcare system, the economic impact on hospitals and on healthcare workers is different because they're not losing their revenues. They're not losing their main revenue stream of elective procedures.
Okay. Someone asks, this kind of goes along with what you were just saying, but with only less than 5% of the world's population, why has the US had more than 30% of coronavirus cases? And I would say that's probably has to do with our differences in social distancing measures, but would you say it's more to do with our healthcare system, or is it just with the government response in general?
Well, that's a tough one because it's hard to know what went wrong when it's clear that a lot went wrong. So I think we responded quite late. In many other countries, the social distancing measures had been placed earlier. In the early weeks of the pandemic, even in New York City, as cases were spreading, the mayor was still telling people that they have nothing to worry about and they should go out and eat, and schools were still open. So I think definitely a delay in responding. And then there are other issues at stake. I think some of it is we had very limited testing initially. So if we had implemented early testing and tracing, we would have been able to curb the community spread earlier. And I do think that in some ways it's true that we have high incidence of chronic disease, that we're not quite sure why it affects the course of coronavirus to the extent it does, but it is clear it does. So I don't think the answer is, Americans are just sicker than other people, but the answer is that we have, decades of underfunding of public health services, hitting a underfunded public health service, sicker individuals, people who are already having poor health and struggling. And so that was kind of excess beyond what we would have expected. And then I think, not having access to health insurance or healthcare, certainly it's an issue, but I think most people who were sick enough to go to the hospital, they just went to the hospital and the hospital admits them. So I don't know if that had the same impact as in other cases where lack of access to health insurance it can increase mortality. And it might be a while until we find that. So I don't know that there's one singular answer, but I think we should learn a lot from this. We have so much technological and medical capabilities, and yet we're struggling to respond to this pandemic, both in preventing the spread, but also caring for the patients who are sick. Not to mention, initially we didn't have enough protective equipment for doctors and hospitals, so there was spread within hospitals. So there was a lot at play here, and I think we'll be learning these lessons for decades to come.
Other countries have managed to contain the spread of the coronavirus through a very intensive test and trace system. Do you think that that's feasible for the United States to implement, especially given that each state has their own plan for reopening? How could we come about to have a more centralized system?
Yeah, it's really tough. We need good national guidelines that inform states as they reopen. The CDC came out with some guidelines, and then they were squashed, and then they came out with new guidelines that essentially said, be well or take care. It really kind of anything goes kind of thing. So yes, we need to implement testing and tracing. It won't have the same impact as if we had done it early, because now we're struggling and we're lagging behind. But as we reopen, we're going to have to do that. But when states, when people come from different states and there's travel and interstate travel and commerce, and each state has its own standards, it's going to make things a lot harder. And some restrictions on travel and requirements for quarantine when passing state lines might be necessary when we're looking from places that don't have a robust structure to those that do. So I think we do need, we will be able to implement, and at least some states that are actively working to that. I think New York is headed in the right direction to having adequate testing and tracing, and that we will be able to have that in place. But what are we going to do when someone, when we have populations coming from out of state? And I don't know that there's good answers to that in the absence of federal leadership, because each state, even states that are really responding well, they're at the mercy of other states and federal guidelines to how they can handle this interstate issue.
We're almost out of time, so we only have time for one more question. Tara wants to ask about how New York State is handling the reopening. Do you think the reopening plan makes sense? You're a physician that works in the Rochester region, so do you think that the plan is feasible in order to prevent a second wave of cases from coming?
Well, I don't know that we will be able to prevent a second wave. It might be that we will do everything right and a second wave will be inevitable and we'll have to scale back. In other countries that have reopened, there's always kind of open and closing and they're just going to be back and forth. So I don't know if the benchmark will have to be that there will not be a second wave. I wish we could do that, but I'm not sure that will be possible. In general, I think the measures for reopening are measured. I didn't mean to do that. I think that this is a thoughtful way to do things, but there are still many barriers in place. A lot of them also have to do with how we care for our vulnerable and where individuals from nursing facilities are going. So initially, hospitals could discharge individuals back to nursing facilities, and nursing facilities could not say no. The new guidance is we cannot discharge COVID positive patients to nursing facilities. So it becomes a situation in which the hospital becomes the site of long-term care for individuals from nursing facilities. So we do see rising numbers in our region. And Dr. Mendoza, our public health commissioner here, has addressed that. So we do see as if numbers are rising. So there's a lot of different moving parts here. I think in general, the push to slowly, measurably reopen with testing and tracing in place is reassuring. But if we don't pay specific attention to these areas, jails, prisons, nursing homes, and so on, then all our effort will be for naught, because we are all in the end one community, and there is going to be intermingling between all these areas.
Thank you to everyone that submitted questions. Would you like to make any final remarks?
I just, thanks for all the questions. I wish I could have answered all of them. It was a pleasure talking to you about what I think are health policy lessons from this pandemic. And my hope is that we will, we'll be able to rely on our historical knowledge in order to affect policy change. All right. Thank you very much.
Thank you, Professor Raz and Victoria, for that wonderful session. Thank you all for joining us today. We hope you have enjoyed this program, and we would love to get your feedback. Please take a moment to share your thoughts about the session. There's a brief anonymous survey. The link for that will appear on your screen at the end of the webinar, and then you can select continue to get to the survey. Please also plan to join us next week, Thursday, May 28th at noon Eastern, for our next Experience Rochester lecture. That will feature Professor Narayama Koshlakota and his talk on the economy during and after the pandemic. Have a great afternoon. Stay well.